Hi, everyone. Welcome back to our Coping and COVID-19 webinar series through our Child and Adolescent Psychiatry portal. We are really excited to welcome some amazing speakers today to talk about Trauma-Informed Pediatrics 101. And so by way of introduction, wanted to introduce Dr. Joanne Jung, who is a general pediatrician in UCSF's Division of Developmental Medicine. She also directs the Resiliency Clinic at UCSF Benioff Children's Hospital, Oakland, and she helps in organizing educational events for the Child and Adolescent Psychiatry portal. Shelly Nakaishi is a nurse practitioner who has been working in the Department of Psychiatry at UCSF Benioff Children's Hospital, Oakland for the past 14 years, and was one of the first trauma-transformed trainers in Alameda County. She has previously served as interim psychiatry program manager in the Department of Psychiatry. Miriam Rue is the medical director for UBCP Bancroft Pediatrics. Under her leadership, Bancroft started doing ACEs screening early this year, and she has been working through trauma transformation ever since. Bancroft was also the first site to sign up with the CAP line and was one of the first sites to collaborate in the Find Connect program. And with that, I'll turn it over to our speakers. And just with some housekeeping, if folks can please mute themselves if you're not already, and ask questions through the chat feature, and we'll be checking those. And we'll be saving questions for the more interactive components that will be led by Dr. Rue. Thank you.
Wonderful. Thanks so much, Petra. As Petra mentioned, today we're going to be talking about trauma-informed care in pediatrics. And first, we're going to be talking about the basic principles. So some information about the psychobiology of trauma, as well as some foundational trauma-informed care principles. But the later part of this talk is really going to be an interactive discussion, talking about how do we apply these principles to decisions that we're making right now, about how and when to open our offices, and trying to approach this decision-making from a trauma-informed lens. So none of us have any relevant disclosures in terms of finances or conflicts of interest. So let's start with the basics. What exactly is trauma-informed care, and what are the principles that underlie it? And it really starts with a shift in perspective. And if you remember nothing else from this talk, this is the thing to take away and to remember. We begin with this shift from thinking about what's wrong with you to what happened to you. Now in medicine, I think we're often trained to hone in on what's wrong and how do we fix it. It's just kind of this rapid reflex that is just like a very deep part of our clinical training. And it's also very natural for us just as human beings when we see a kid running around in frantic circles and destroying our exam rooms, or a parent yelling at our staff in the front, to just immediately jump to what is wrong, or like what's wrong with this kid, what's wrong with this person. But the trauma-informed perspective invites us to stop that rush to judgment, take a step back, and look at this anew, and look at this fresh from what happened here, what happened to this person to lead to some of the challenges that we're seeing now. And this is a perspective that's very deeply rooted in empathy and in listening and in understanding. And then once we make that shift from what's wrong with you to what happened to you, we're poised to make another shift, to recognize the strengths that are embedded, even in some of our most seemingly vulnerable or challenged patients and families, and really looking for and validating all that is right with them. So when we're interacting with children and families that have experienced trauma, it's really helpful to have a basic understanding of what's happening inside the brains and the bodies of children and adults who have experienced traumatic events. And this sort of understanding really helps us to understand the roots of some of the behavioral, developmental, and the medical challenges that we may see in children who have experienced traumatic events in their past. And with this understanding, we can really help to connect the dots for a lot of our patients and families. So this can, in the right way, invite greater kind of self-reflection and self-compassion for how past diversities are influencing present. So I think most of us know that stress can really affect the brain. So the brain has like these higher level executive functions that are located in the largely in the prefrontal cortex. It's located in the blue here. And that's responsible for things like our rational thought, our executive functions, our planning and focus, self-regulation. And this is the thinking brain. However, for all of us, when under enough stress, that thinking brain can really go off. And it leaves some of the lower centers of the brain, and the parts of the brain that are responsible more for emotion and for basic survival. So instead of thinking through our actions, we can go into fight or flight mode, reacting quickly and sometimes emotionally and forcefully. And in really severe stress, we may even freeze, going even deeper into the basic survival part of the brain. So for someone who's thinking brain or acting in a dysregulated way, it's just physiologically difficult to access this like more rational, the rational capacity for thinking. So let's unpack that a little bit further. So we all experience stress, but not all stress is the same. So there's a more day-to-day kind of stress of like facing a busy day or taking a test or like an overbooked schedule. And our body's prepared to meet that challenge by produce this increase in the production of adrenal hormones, including epinephrine and cortisol, and all that makes our heart rate go up. It makes our breathing a little faster. It elevates the blood sugar level, causes us to sweat. Our bodies are just getting ready to like run to meet like a big challenge. The important thing is that at the end of that challenge, the stress response goes off. Our bodies have a chance to rest and they have a chance to recover. And through all of this, that thinking part of the brain is still in control. We can still access that rational kind of. So that's normal stress. And actually, many times as we rise to meet challenges that can be good for us, it can be positive in that it invites higher productivity, and allows us to actually grow through meeting that challenge. But then what happens if we face something that's actually traumatic, that and that overcomes our ability to cope, and either because of the severity of the event or because of the lack of supports and relational supports around us. And then in these cases, like we kind of go out of that thinking brain and we kind of go deeper into that emotional and survival brain being more in control, thinking brain being offline. And if the stress is severe and prolonged enough, this normal physiological stress response that helps us get through challenge, it doesn't turn off. We don't get that chance to rest and recover. That heart rate may stay persistently elevated. These adrenal hormones may stay persistently elevated. And not only that, this inflammatory cascade can also get activated, providing or creating further wear and tear on our bodies. And the way this can show up behaviorally is in irritability or impulsivity. It can show up as hypervigilance or hyperactivity, such as that kid running around that exam room and just tearing it apart in front of our eyes. Difficulties regulating big feelings and emotions, learning difficulties, problems sleeping, problems eating, and as the inflammation like gathers steam, it can cause further changes to our immune function, our ability to fight off infection, and just overall changes to our bodily regulation of stress over the long term, as epigenetic markers get left on our DNA and like even change the way our DNA is read. And if this happens during developmentally critical periods in childhood, it can actually affect brain architecture and the way that the brain develops. That can, over the long term, affect the learning and development and attention and focus. And so these developmentally critical periods early in childhood are very much part of the reason why we pediatricians have a real opportunity to recognize when this may be happening to our patients and hopefully to be able to step in and intervene and make a real difference in the lifelong trajectory of the child. Now, the thing is that this kind of affective trauma may not only happen to individuals. We argue this can happen to organizations and this can happen to communities. And I think we are in one of those moments where we're recognizing um, that communities also can get traumatized and that not just individually, but collectively, we're experiencing irritability and difficulties in sleeping, difficulties in concentration, this kind of like hypervigilance and being on edge. And when this affects like organizations, you can see um, the, the capacity of the organization to kind of like help care for the people within and to meet its goals definitely can take a big hit. And so part of an understanding of trauma-informed care extends not only to how we interact individually in the exam room with our patients, but also how we view the clinics and the organizations that we work inside. Because we work within these contexts, and when all of this is going on inside an organization, it becomes difficult, if not impossible, to actually provide this trauma-informed kind of care individually in exam rooms with our patients. So with that, I want to turn the presentation over to Shelley to talk about how trauma-informed care operates within organizations.
Thanks, Joanne. Before I begin, I wanted to provide a little more background about Trauma Transform, also known as T2. T2 was created for a SAMHSA grant and led by East Bay Agency for Children to be a Bay Area clearinghouse promoting a trauma-informed system by providing trainings and policy guidance to systems of cares, professionals, and organizations. The trauma-informed system training was actually started at San Francisco General Hospital by Joyce Dorado and Lynn Dolce, then adopted by San Francisco Public Health in 2012, and delivered to all county health departments and staff, from director, providers, administrative staff, food service staff, cleaning staff. All employees received this training. Today, I'm going to condense this 3-hour presentation into a 15-minute highlight reel of what is a trauma-informed system and why might we want to have such a system to help ready us for our system changes needed around our two major public health crises right now, the pandemic and racism. If we look at the plant graphic to the right, for any major system and cultural change, we want to take a systematic approach to these changes, starting with the readiness assessment. And then another critical step is gaining leadership buy-in, and then finding sponsors through work groups, and the major task of training all staff so everyone is speaking the same language. For ongoing development, we'll need to infuse the trauma-informed principles in the strategic and financial planning and all the policies and procedures. We may have seen some wonderful trauma interventions for our patients, like ACEs screening or building in behavioral health integration services into primary care. And we may have also seen that if we don't start with the leadership and staff buy-in, some of these interventions may not continue to thrive. The graphics here were taken from a book entitled Trauma-Informed Healthcare Approaches, A Guide for Primary Care by Megan R. Gerber? Yeah. All right, next slide. All right, so how do we get to this healing system, this trauma-informed system? This housing metaphor shows that we can all have wonderful types of trauma interventions, like the chair on the left side, representing pearl screening, trauma-focused CBT therapy. But without a strong foundation and housing structure, the furniture may break down in major storms. So if there's not a trauma-informed workplace, we may not be able to provide the best trauma-informed care. And the foundation and structure to a healing system are the guiding principles of a trauma-informed healing system. And the foundation starts with what Joanne first discussed, which is understanding trauma and stress. And another key principle is cultural humility and responsiveness. The structural principles include safety and stability, compassion and dependability, collaboration and empowerment, and then the last is resiliency and recovery. Thus, a healing organization has infused all of the trauma-informed principles in all of the work practices and policies, from hiring, training, communication, supervision, physical structures, staff wellness, and treatment interventions. Okay, next slide. Cultural humility. We have come from diverse social and cultural groups that may experience and react to trauma differently. When we are open to understanding these differences and respond to them sensitively, we make each other feel understood and wellness is enhanced. This is a foundation and principle, and infusing this principle in all of our practices. Um, it should become a norm about policy decisions to ask, how may this impact different cultures and communities? And we know that during this pandemic, it has impacted Black and Brown communities more. And how might we address this in a trauma-informed way? Some providers may have started asking more about social needs for patients due to the pandemic, like food, housing, childcare needs. And while we may want to act quick and to address and provide help, we may want to think of it in a trauma-informed way by asking families and making sure to inform them why we're asking for permission, giving the option to opt out, and making sure we only ask it once, and making sure we kind of get input on how to ask in a culturally sensitive manner. Other shifts in clinical practices may be even bigger questions, like a Spanish-speaking clinic. How can they be more inclusive to other ethnic groups? And it may even be smaller decisions like the selection of the waiting room music. That's a quick overview of cultural humility and responsiveness. There's a lot more to talk about it, but for our 15-minute reel, next slide, please. Safety and stability. Trauma unpredictably violates our physical, social, emotional, and safety, resulting in a sense of threat and need to manage risks. Increasing stability in our daily lives and having those core safety needs met can minimize our stress reactions and allow us to focus on our resources on wellness. So if you look at the CDC, our physical safety is of utmost importance for everyone's sake. And we might want to start using a guide. The CDC has a guide for reopening, but we also want to think about, if we set up any barriers, how might this have different impacts to staff, patients and families, and cultures and communities? Another area we may not consider, but is really important, is emotional safety. And with the trauma-informed lens, it's looking at like how to create spaces of communication, and some tools that folks have used for groups are ouch and oops. So if someone says something that's offensive, they say oops, or if someone felt offended, they would say ouch. And this allows for an assumption that we're all trying our best. It's intent versus impact. And we are also transparent when we are hurt, so we don't have to hold it in. Another area of safety and stability is predictability. And so consistent routines like helps patients and staff. So for example, when I went to Kaiser to get a COVID test, even though I was stressed about the results, the procedure was quite simple. The information from my provider to the immediate email I got to the security guard and the testing provider was all the same. It was clear and consistent. It was on time, and everything was really well marked. And also it did not hurt. Okay, so for what Joanne discussed, stress impacts our ability to listen. So we'll need to communicate clearly, consistently, accurately, and repeatedly. Next slide. Compassion and dependability. Trauma is overwhelming and can leave us feeling isolated or betrayed, which may make it difficult to trust others and receive support. However, when we experience compassionate and dependable relationships, we reestablish trusting connections with others that foster mutual wellness. So teaching staff how to reframe challenging behavior in the clinic, like an angry parent yelling at the registration clerk, from a trauma lens of what is wrong to what has happened to this parent, and not knowing that this parent is actually stressed about housing. And during this time of shelter in place and physical distancing, we are all experiencing the importance of social connectedness to our well-being and mental health. In clinic and work settings, we have new challenges arise from working remotely and helping staff to feel connected. And having staff huddles now become the time of connection. And so how do we help our leaders keep these huddles to foster community? One example that a UCSF psychologist helped to do on setting up some huddles for clinics was they would have a set time to talk about the staff's own personal issues and stress around the pandemic, and then they would share a moment of silence of support. And so by just having this time of reflection and sharing, they definitely built more compassion and connection amongst the staff. Next slide. Collaboration and empowerment. Trauma involves a loss of power and control that makes us feel helpless. However, when we are prepared for and given real opportunities to make choices for ourselves and our care, we feel empowered and can promote our own wellness and the wellness of others. And so, personally, for me, what helped me get through my first stages of the pandemic was that I was totally focused on building out our telepsychiatry procedures. Never mind that I had a 10-year-old screaming in the background, with two parents working. So it did help me. And so for primary care setting, how can we ensure we empower our patients and staffs with policies and procedures, especially as we develop reopening procedures? And we'll discuss later, but part of the Trauma Transformed Audit Tool helps provide a reminder question. Was this policy created with a cross-section of input from stakeholders, staff, consumer, community, leadership, county, and state? Okay, last one for me. Resiliency and recovery. Trauma can have a long-lasting and broad impact on our lives that may create a feeling of hopelessness. Yet when we focus on our strengths and clear steps we can take towards wellness, we are more likely to be resilient and recover. Helping folks recover and build resiliency includes highlighting strengths of the patients, the staff, the clinic, having a shared purpose and goal, building ways to feel grateful, and to celebrate together. Um, at the New York Mount Sinai Beth Ezra Hospital, they actually changed a testing tent to be a new staff lounge with leather recliners, plants, aromatherapy, and video scenes that you can pick from tropical to campsite fires and music. Okay, and I'm going to end with a quote from Maya Angelou about relational healing. I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And so I'll turn it over to Dr. Rue, or Miriam.
Thanks so much. So for this next section, we're going to be talking about how to apply all of these trauma-informed principles that both Joanne and Shelley so expertly described. And we thought that we would use that to talk about how we are making all our decisions about how to further open up our clinical practices. We do want this to be really a time of discussion and sharing, so we hope that you guys all actively participate in the discussion section. Next slide.
Sorry. For some reason, okay, there we go.
As it's already been alluded to, there has been a lot of collective trauma over the last several months, starting with the COVID-19 pandemic. We all have a lot of anxiety and worry over the health and safety, not just of our patients and their families, but our personal safety, those of our personal families, and what happens in our communities. And then more recently, there's been much more acknowledgement of the racism that is occurring not just in policing, but also in the medical system. As Shelley alluded to, we know that it has been different for Black and Brown people in terms of the care they're receiving. And so that causes stress. And, a lot of us notice it in our everyday lives as well. And so that brings about a lot of the stress that Joanne discussed. And, again, not just individually, but kind of as a collective whole. Next slide. And we realize that, even though we are all in this same storm, we're actually not in the same boat. We all bring our past experiences into the picture. And so the way that we react to stress is different based on kind of the groups that we're in. And, I can say for myself, how I acknowledge the stress and deal with it one day can be completely different from another day, and even hourly sometimes I'll react differently. And so that's just a reminder, next slide, that anytime we make these decisions to apply these trauma-informed principles, we want to consider all the stakeholders and not, pre-COVID-19, I would say we had a lot more focus on our patients and their family members, the physicians and staff. But, we recognize that, now we often have a lot more impact on our own family members in our offices and on our neighbors, both at work as well as at home, and just in our broader communities, from locally all the way, I would actually add globally as well. Next slide. So this is back to the slide that Shelley showed earlier. And we were one of those practices where, we started doing the ACEs screening last year and then did the referral through the Find Connect program. And so we had that furniture in place, but we really did not have that foundation or structure in place as well. It was always something that was kind of in the back of our heads, like we really should do this, we should do this. And we didn't really hold on to it until we all started feeling the trauma ourselves and realized that we couldn't continue on without addressing it more head on. And so that's what we're doing. So, just consider these principles when we're having our discussion. I'm going to admit this person. Next slide. All right, so the first thing that we're going to talk about is how can we provide trauma-informed care just in terms of our physical environment and in terms of our physical safety. So this is some photos of Berkeley Pediatrics, and what you can see. Can you guys see my arrows, or is that just me? So, Berkeley Pediatrics started putting up all this plexiglass. And the second picture from the left, you can see they've got little holes to kind of slide in your things. They've got, the shower curtains to separate things out. One fantastic thing that they did on the right is they got some garment hangers and added some plexiglass. And the doctors actually did this on their own, which I thought was super creative. And so those are both in the waiting room as well as in the shop room. And so we wanted to actually have a little discussion about, what are your thoughts in terms of, is this, how does this provide trauma-informed care, and how does it not? I know for me, when I went to Safeway for the first time and they had their plexiglass, I felt traumatized because I was like, what do you mean there's this plexiglass here? Like it feels so distant. I don't like this, I'm already wearing my mask. Why do you need the plexiglass? So anyway, we'd just love to hear some of your thoughts, as well as if your offices are doing things differently to promote physical safety. Go ahead and go to the next slide. So as we're thinking about it, we want you to consider who are the stakeholders and then what, in the trauma-informed principles. Okay, you can unmute everybody, I guess. My son, of course, decides to play piano right now.
I personally, I guess I wasn't traumatized like you, Miriam, because I just felt more safe at the grocery store with the plexiglasses. I'm talking to the cashiers. I don't have any major underlying problems, but still, I didn't want to get sick. And I felt safer, but it feels a little distant because nowadays that's my only human contact.
Right.
So.
Exactly. Yeah. I wonder that for our patients, does that actually make them feel more safe, or does it actually make them, because I know our staff also, they don't want to take anyone's credit card. Right. So they just say can you just show it? I was like, just take their credit card. So it's been interesting to talk to them about that kind of stuff too. Yeah. Other thoughts?
I know in our psychiatry department, we also share an office space with ophthalmology. And so we have to do a lot more negotiating about how do we want, families to come in.
Mm-hmm.
And we haven't even, they are coming in with, there's a lot more ophthalmology patients coming in than psychiatry patients because we're doing all telepsychiatry. So it just brings up a lot of cross collaboration of how do we negotiate this physical barrier space if we're going to bring any physical barrier space in, or
Yeah.
is there a setup?
How have you guys negotiated that?
Yeah, that's still a negotiation, but I think they just only allow certain number of patients to come in, one at a certain time, so that separates the waiting room issues at this point.
I think just thinking about, intention is different than impact, and that there's a risk in all of this of things being kind of taken out relationally when that's not the intention, and being really, just accepting both the fact that we have to have these barriers in place and that we would all love to have, to go back to our pre-COVID existence, right? And not have the need for any of this, but just acknowledging that, yes, we do need to wear face masks, or we need to have the plexiglass up, and we need to have these barriers. And then those are the swim lanes, right? Those are the rules. And then from there, we can work things out relationally. But I think like being able to humanize things, it's extraordinarily hard. And so I think just like naming that explicitly, like these are the rules, and to have it be very clear and explicit. And then from there, we can make jokes about how we're going to accept the credit card or not, right? Or like, being able to connect.
I wanted to give another example with the physical barrier space. We had actually locked the front doors because at that time, no patients were coming in. But we also didn't have any front office staff. So if I had asked to have the doors locked because nobody was up front, and anyone could walk then into our back offices anywhere. And so by me locking it, I really upset other people in the office. And I was like, but I'm protecting also the space and other people walking in. But so that physical barrier created, as Petra was saying, a lot of issues came up relationally of not understanding why I did actually lock the door. Nobody was at the front desk.
Yeah, that's actually a great example, and it segues right in perfectly into our next slide. Thank you. And so now we're going to talk a little bit about, how we bring these principles into kind of how we bring patients into our office and kind of the more social safety part of it. And we also did the same thing. So when COVID started, we had locked our front door because, we, our waiting rooms often are very filled, and we had books and playthings in there, and we just wanted to have a little bit more control of, the flow. And so we locked our front door. And then we initially had just a little slide that you see there in the middle of our door that said to please call our office. And it was, right into our back line. And then and then we would let them in. But what we found was that a lot of families were actually, they would get to the door and they wouldn't read the sign. And then suddenly they'd be yanking on that door and kind of, I'm sure, feeling some trauma from not being able to get in. And then the staff was hearing them yanking on the door. And, they were unsure, like, oh, do I just open it anyway? Do I just, get on the phone? And so they were doing a lot of this, like, call me, And so one of the things that we did to respond to that was actually to create these larger signs. And actually the original intent was for them to be able to stay in their car and to call us. But as you can see, they're still coming to the door, but they are now reading the sign and calling our office and not having the trauma of the locked door. And so, what we talked about earlier, having that communication and having it early is really helpful. And then, we do have our signs in English and Spanish because we are also one of those clinics that mainly has a lot of Spanish speaking folks. But yes, more languages would probably be helpful as well. Another thing that we have kind of evolved is our screening questionnaire. So we don't actually take temperatures at our door. And initially we were, having them call, but we would just bring them in. And then we found that, folks, even though they were getting asked over the phone if they had fever or cough or any symptoms, they were actually pretty fearful about naming those because then they thought that we wouldn't see them. And so for a while, we had some patients that were coming in with those symptoms, and then only once the doctor went in there, then they would say, "Oh, my kid's been so sick," and we were like, "Why didn't you tell anybody ahead of time?" So we developed this screening questionnaire, and it's evolved. And so we ask, in the last 7 days, has anyone had any of these symptoms? And we're naming each one individually. And then we add in the question, has anyone taken medication? Because we found that some parents were giving their kids the Motrin, just 6 hours prior, so that they wouldn't have a fever when they came to the visit. And then we asked about, has anyone been diagnosed? Because sometimes they would say, "Oh, we've been fine," and then only to find out that like 3 days ago, someone in the family was either diagnosed or tested for COVID. So, and then the other thing that we do is that we actually have our physicians do the screening whenever we can, because we found that the families were often a little bit more worried about not getting in if they talk to the staff. And so we felt that if we were able to talk with them, then they would be a little bit more forthcoming, and then we could say, "We're still going to see you. We're still going to take care of you. It may have to be in the car rather than in our office, but we will take care of you." And so those are some of the things we did. So we'd love to hear from you now. Again, we're going to pull up the next slide, which is just kind of the framework about things that, any thoughts on stuff that we're doing, and then also anything that you guys are doing in your offices to bring patients in safely. Do you guys feel like these the signs are, like what I think with Shelley, some of our staff is actually pretty opposed to having the doors locked, and some of our staff is like, "These are going to be locked forever." So I'd love to hear some of your thoughts on, the closed door or the locked door in particular. Are your doors still locked, Shelley?
Yes, they are still locked. I was just going to say, they get locked after 12 o'clock because the ophthalmology clinic has a lot of patients coming in and out. So when they're open, the doors open actually. But when that clinic is closed, then the door is locked. But we also have a testing site too. And so the other challenge is you have an open door and you have people getting tested over along the side. And then they started coming in to the office, like, "Where's the testing site?" We're like, "Ah!" So then we had to create these signs, that says testing is over here. And somebody keeps moving the sign a little further away. And I'm like, "No, you got to have the sign in front of the door." Yeah, so that's been my personal challenge.
Yeah.
But signage is really, really important. And the explanation of why, I think, is also important. And each time we learn something new, "Oh, we forgot to tell them this information."
Right. Yeah. Our list of things that we tell the families at the end of each phone call has just gotten longer and longer. It used to be like 3 sentences and now it's 10. And we even added one today about masks. So yeah, because we had this patient come in today who had a Black Lives Matter mask. And we asked that they put the surgical mask on top because that's policy. And then they were like, "Are you trying to silence me?" And we were like, "No, we're actually trying to follow policy." So it was interesting.
Wow.
Yeah.
How
So
did they
yeah.
feel after you told them?
Then what she decided to do was to put her mask under the surgical mask underneath, and then put the Black Lives Matter on top, which is probably not the original intent, but we felt like that was good enough. Yeah, great. All right, so I'm going to the next slide. So the last thing is kind of about providing emotional safety and how do we communicate in our office. So one of the things that we actually started early on was the daily huddle. And we do it, whoever's in office, we do it in person. And then whoever is at home, we ask them to join even if it's their day off, we actually, if they can, join in on the Zoom meetings. This is a great way for us to, communicate the same information at the same time. And we felt like this was really important because, the information changed, on a daily basis. And so just sending out the emails, again, we're all on email fatigue. And so we felt like that was not going to work. And so we wanted to make sure that everyone heard the same message at the same time so that they can convey the message, just like Shelley was saying, so that, every person that a patient meets, is all saying the same message. That was one reason. Another thing is that, we knew that people were under a lot of stress, and that, talking it out really helps. And so, at the beginning, especially, we spent a lot of time just saying, how are you feeling? And just letting every person in the office talk about how they were feeling that day. And then, if anyone was under, a lot of stress, to talk to them, just to let them have their voice and to give them that space to talk. And then, figure out if they needed to go home or if we needed to refer elsewhere, things like that. And this is also a great time for us to really collaborate with each other, and to make decisions together. So, things that we just discussed before, all those signs, those were pretty much all staff made decisions. We actually before made a lot of decisions kind of top down. We're going to do it this way and you guys are all going to follow. And now we're actually making a ton more decisions where everyone's, working together to make that decision. We all agree it's the right decision for, the vast majority of people. And, they're out there making the signs. They're like, oh no, we need to add this to the sign. We need to do that to the sign. And in these last last month, with the increased racism discussions, we actually started a, tell us your story. And so now during the huddles, we actually highlight one person a day to, tell their story and talk about their cultural background. And it's been really interesting to hear everybody's stories. And we talk about, how, things are a little bit different for each of us, and also how things are the same, right? Some of us have had parents who passed away from different cultures, and some of us, are immigrants versus not immigrants. And so it's been great to kind of see how, even though we're all very different, a lot of our, lives are actually pretty similar as well. And so that's actually really helped with communication as well. And so that's one of the things we're doing. So go to that next slide. All right. So same slide again. And just love to hear some of your thoughts on how you guys are increasing communication in your office to meet some of these trauma-informed principles. Anyone else doing huddles?
We definitely have huddles twice a week, but I'm going to take some of your practices, Miriam, and see if I can get us to do some of them, because you really do combine so many aspects of the principles: cultural, compassion, collaboration, empowerment. So yeah, I definitely love all that you've done with the huddles.
Thanks.
Just a logistical question. How long do your huddles take in the morning?
We do half an hour.
Half an hour.
Yeah.
And another question that kind of came up for me is, how did you make that shift from being more top-down decision-making to something that was collaborative? Like, how hard was it to make that shift, and what was involved in signaling that this is now a new way of
Well, yeah. So like I said, a lot of it was, COVID-19 came and we needed a way to make sure that everyone was getting the information and they were hearing it all at the same time. And so that's when we started. We weren't doing the huddles beforehand, but then we started doing them. And we initially were just doing them like, Monday, Wednesday, Friday. But then some of our staff is not there on certain days, and they were like, we're missing out. So then everybody wanted to do them daily. So then we started doing them daily. And then we realized that, you know, a lot of that shared decision making was so much more powerful when we could do it together. And the buy-in was so much better when we could do it together. And so we just continued it on. And every time that I say, like, do you guys want to do this less? Everyone's like, no, we like them. Because I think that it's actually a great time because, you know, in our offices, we're trying to all physically distance ourselves. And so, you know, we've told them, like, you have to stay in your corner, right? And you can't come out and be like, you know, hobnobbing with everybody, you know, all day long like you're used to. And so I think it's been a good time because that's the time that they can really spend with each other and then learn from each other. So, yeah.
And Jean, you and I could talk about this too. In our huddles in the very beginning, how do we develop all of our telepsychiatry procedures and who gets to work from home and who doesn't? And, you know, we are as transparent as possible in showing what are the different options and then getting everybody's input into what option felt the most safe for everyone and most equitable as possibly we can. So, you know, that was our process for who can work remotely and who cannot. So that was definitely huddle use of time and being transparent and getting everybody's input.
Yeah, I also talked to some of my former colleagues who are in primary peds, and a lot of them are in the fertile period, so they're pregnant, and I think that came up a lot, like in terms of not feeling safe, seeing sick kids, and potentially contracting COVID. So I think they were thankful that the practice was accommodating so they could see relatively clean well checks and pull them out of sick care. So I think that's something that some of the providers are nervous about if the practice has capacity to accommodate.
Are you guys doing a lot of telepsychiatry or?
Pretty much 100%. We do have a procedure set up for and a procedure set up to see if we needed to, if there was a clinical reason to see them face to face. And then we also set up procedures on how would we support each other. We'd have an MD there and an NP there, so we'd have two providers in case there was a crisis.
Yeah, it was interesting. I was at a different, I'm kind of veering off a little bit, but different meeting, and they, one of the community pediatricians was actually saying, like, I don't know why, you know, psychiatry has to be over Zoom. You know, I wish it would be in person. It's so important that it's in person. So it was interesting to hear her point, because I was thinking, like, you know, I mean, I think telepsychiatry is perfect because you can kind of, the patient's more relaxed and in their own home, right? And they're not having to make the big drive, and you can do so much over telehealth. But she felt like, you know, some of that social connection was lost. So
It is true. There are definitely positive and challenges. We can see a lot of group home patients now that are really hard to have come into the clinic. So we can see them quickly and observe them and more often. However, for new intakes, it's a lot more challenging, and especially if the families don't have they have limited internet access, or they're just doing it on the phone. That's the real drawback for us, and that's really hard. So I think we still have work to do and room to grow on how to resolve that. But for our existing patients, it's been working out really well, and they feel safer. And I've actually been able to see a lot more patients.
And just to add to that, I think there's a need to kind of look at the both and in this, that again, we wish we could go back to in-office, pre-COVID, not a worry, kind of thing. But the reality is that, yes, there are some limitations in some ways to, telehealth, in particular for folks who don't have stable internet connections, I think is the biggest thing. But the reality is, if you come in office, you can't see someone's facial expressions anyway if they're wearing a mask. And so,
right.
You get to see inside someone's home. You can meet with family members who otherwise would never have made it to visits. You get to have different components, maybe, of a visit in terms of family constellation. And so I think being able to hold that both and is really important, and not to say, oh, it's just so limited, because, the reality is, like, everyone's wearing a mask and it's super hard to make it in.
Yeah. Yeah, we've definitely, it's been great for our patients, especially with chronic care needs. And, like, it's such a challenge for them just to get out the door. And so now I can see them every week, and really just check in. And, it's actually a much more kind visit, I think. The family's not coming in completely stressed out. So great. Okay, so I think Shelley now has some resources to share, again, from Trauma Transformed. I think you're muted, Shelley, or maybe I. There you go. I hear you now.
Sorry, yeah. Let me get back to share my screen. All right, so this is a Trauma Transformed website, and they have tools under Trauma Transformed tools. So they have things about an environmental scan, a checklist. This is the audit policy tool tip sheet, which kind of tells you why are we asking these questions. And some of them, the audit tool asks, it's just it's a reminder when you're implementing a policy. It tells you, goes over the TIS principles, and then, ask these questions. Is there a clear purpose? Was it created with cross-sectional input? Are there potential positive impacts or potential adverse trauma-inducing? Are there ways to modify, reduce harm? So it's a guide that you can use into implementing a policy. And then another tool that I also found is from the National Council of Behavioral Health, is a trauma-informed primary care, fostering resilience and recovery. And it pretty much outlines what we just talked about in much more details, and gives you examples of clinics. And it actually gives you scripts of how to respond to certain things that may come up with staff or with patients and families. So a lot of the trauma-informed principles, may not totally line up with exactly the way we presented them, but they have all the same content, basically. So those are the main tools I had to share. Does anyone have any questions about those tools? Or any in the chat, or they want to unmute and join in? Okay. So if nobody has anything more, does anyone else want to add anything to the final part of our webinar? I do want to thank everybody for joining, and I really want to thank, it's been great collaborating with Miriam and Joanne. So that's been a really nice distraction from all the other challenging things during this pandemic, and helping me to refocus again a little bit more on having this lens in, as we all, our own personal, going through our own trauma into the current situation, and trying to find meaning. So I want to thank them as well, and Petra and Nate for helping to set this up.
I'd like to echo that same gratitude. It's been wonderful collaborating with everybody, and yeah, again, helping me to really focus in.
Likewise, and sorry my internet connection was unstable. I'm glad you were able to get everything up and running again.
Thanks, everybody. So we'll end here, and we hope to see you on July 2nd for managing with early childhood age group and parenting. So we look forward to seeing you then. I'll be with Barbara Ivins next week. Thank you.
Thank you. Goodbye.
Please send in your evaluations. It's required for CME. Thanks. Bye.